our series, we have a treat for you tonight because Maureen and I are part of what we call the ONJ working group. And we've put together a slideshow, slide deck, as well as a presentation about dental health generally, dental health during chemotherapy, and a topic that can be a little bit scary for people, osteonecrosis of the jaw, which is a still relatively rare side effect of the bisphosphonates that we often take when we're diagnosed with breast cancer. What's a bisphosphonate? All right, so that is Xgeva or Zometa, or I think Prolia is also kind of the name of the Xgeva version that's given every 3 months. But bisphosphonates are medications that our doctors prescribe to us when there are bone mets or the possibility of bone mets, because they help to ensure that the bone is able to heal itself, is kind of the easiest way maybe to explain it. A bisphosphonate is also prescribed a lot of times for osteoporosis or osteopenia sometimes as well. Osteopenia is the precursor to osteoporosis. And so a lot of people who are aging will also have these medications, but it's also something that really affects the breast cancer community because legitimately, many of the manufacturers of these medications weren't too excited to accept that their wonderful medications were causing this side effect that a lot of people were struggling with. And so we're going to talk tonight about Dr. Robert Marks, who wrote the kind of groundbreaking book on bisphosphonate-induced osteonecrosis of the jaw. Sometimes it's called medically induced osteonecrosis of the jaw. And he got a whole lot of flack for that. A lot of people were very angry with him for connecting those dots. So, but our commitment to all of you as part of this MBC series is that we're going to talk about the things that people aren't talking about. We're going to talk about the things that people don't want to talk about. And this can kind of be under that heading. So with that, Laura, were you able to locate the deck? Awesome. I thought give you a little bit of time to locate it.
That was perfect.
So,
thank you.
as we begin talking about these really important topics, please feel free to pop a question into the chat. And Laura will make sure that we address any of your questions. But we are going to start with those dental health things that everybody should be aware of. So if you want to advance the slides, Laura, I think we have we have disclaimers. Yes.
Of course we do. I love that.
Yes, we do. So if you've ever attended a scientific presentation, which probably many of you have, doctors who are presenting have to disclose if they're receiving money to present, so that you know about their biases. And so I just want to say up front that any kind of presentation that you attend, knowing the biases of the speakers, where they're employed, where they make their living, where they're getting money from, or honorariums, or whatever they're called, it's kind of important to know that stuff so that you can put what they're saying into context. So there are no disclosures for Maureen and I. Nobody has paid us to do this presentation. We are doing it because we love to educate people. None of us are dentists or doctors. Maureen has been a hygienist for a very long time, probably longer than she would care to admit. And my claim to fame in all of this is that I have osteonecrosis of the jaw. But we can't give anybody medical advice. And so if you have specific questions as to your individual healthcare options or your needs, please seek out qualified medical care. And we are going to talk about in this presentation about those different experts and who might be the best people to have on your team. So that may give you a place to start. But nothing in our presentation should be taken as medical advice. Please do feel free to utilize what we're going to talk about today to talk to your medical providers. But otherwise, please don't share this information. It's not for everybody. But make sure that you understand the context of this presentation. We're not experts. We are people who have done a whole lot of research And we're here to hopefully help guide you along the way.
I think these are great disclaimers. And I would say, as someone who's been on Zometa, but does not have the osteonecrosis, it's something that's really important to just be aware of so we can self-advocate for ourselves. Again, and to add, SBC, survivorybreastcancer.org, is not receiving any funding for this.
Thank you for saying that as well. So yes, knowing what to look for is very important. And we do have some pictures in our slide deck that won't translate too super well into the podcast. But certainly if you want to share some of that, Laura, in the show notes, that would be totally fine with us. All right, 100%. So next slide. All right, so this is our schedule for today. And yes, I pulled some funny teeth clip art when I was putting together this presentation. So we're gonna do this in hopefully kind of a chronological order, right? Dental health considerations before cancer treatment. I realize that many of you have had cancer treatment, and so you're like, why are we talking about this? Well, it lays the foundation for all of the other things we're going to talk about. And I have a feeling all of you know people who aren't in cancer treatment, like kids, like spouses, like other family members or friends. So all of these things are applied in that first part, applies to everybody. Then we'll move into dental health considerations during cancer treatment, what you need to be telling your dentist, what you need to be doing from a dental health perspective while you're taking medication for the cancer. And then we will move into this medication or bisphosphonate-induced or related osteonecrosis of the jaw. And I made sure to put all these different acronyms so that you know it's all really the same thing. Medication induced, medication related. Hello, Victoria.
Hello.
As well as bisphosphonate induced or bisphosphonate related osteonecrosis of the jaw. These are all the same thing. And Victoria's claim to fame also is that she has osteonecrosis of the jaw. So she'll be sharing some of her experiences as well. But if you want to advance the slides, and Maureen will start with before cancer treatment, what should people be thinking about?
Okay, so before cancer treatment, it is essential to visit a dentist or dental hygienist to help reach optimal oral hygiene in order to help prevent barrage. It is important that you are completely honest with your dental team about your medical history. The following services should be performed at your dental visit. With a comprehensive dental examination, you're going to want to have your list of medical conditions, and that's important because they have an effect on the mouth. Diabetes is an example. It slows the healing down in your mouth. Medications, some medications affect the mouth. An example would be blood thinners. If the tissue is torn in any way, you could have excessive bleeding. And the surgeries, the dentists need to know if you've had the surgeries and if there were any complications with the anesthesia or with the bleeding. The general dentists want to know more about the bleeding than they would about the anesthetics, but the anesthesia, the dentists that really want to know about the anesthesia would be the oral surgeons. And I would suggest printing out your medical conditions, your medications, surgeries, a list of important information that you would get from your oncologist, the ANC and platelets, and you can get that from your patient portal. Bring those to your appointment so your dentist can check everything over. You want to have the ANC so that it is above 1. You don't want to have any dental treatment if it's below 1. And if your platelets are below 50, you do not want to have any dental treatment done.
Maureen, can I just jump in and ask, when you talk about treatment, are those the cleanings too? So that if your numbers are that low, you shouldn't even get a cleaning?
Yes, even with the dental cleanings, it should be, if it's below 50 for the ANC, you should not have the treatment because they bring up a lot of blood. And
Yeah.
bacteria in the mouth, there's so much in there, it goes into the bloodstream and it can affect other parts of your body.
And that acronym that you were saying, ANC, that's the absolute neutrophil count, which is one of the elements of white blood cells. And that's usually on a CBC, right? Kind of that general
Right,
blood work that people do. Okay,
right.
just want to make sure.
And I think the platelets come out on that same
Yeah.
panel. And the comprehensive dental examination, they're going to do an intraoral examination and also an extraoral examination. The extraoral examination, the clinician will feel around lumps and bumps all around your chin for, they'll check your lymph nodes and they'll even go in the back and feel around in your back. They'll also check to see if you have any popping with your TMJ and have you move your jaw back and forth. And they will also check your thyroid. And they'll do that by putting their hand on your throat and having you swallow. They'll be able to feel if your thyroid is swollen. The intraoral examination, they're also going to be feeling for some lumps and bumps inside your mouth. And they'll also do a cancer screening. The dental charting is important to find out if you need to have any cavities done or extractions. It will also show missing teeth. We'll chart all of that. The periodontal charting is the health of your gums, and then the radiographs are a great diagnostic tool to detect problems that are going on with your teeth and even with your jaw. And those two x-rays would be for bite wings and also for the panorex. And the oral surgeon, excuse me, the oral surgeon will use a cone beam computer tomography, and also the endodontists will use that, and that's a very specialized way to for a diagnostic tool. The dentist will gather all of that information and they'll do a visual assessment and they will do radiographs, and those are to make the diagnosis and also a treatment plan. A good question to ask your dentist is how many patients they have seen that have active or metastatic cancer. And you should ask them if they feel comfortable treating cancer patients. A lot of dentists do not want to touch a patient who has cancer. And in that case, you really need to seek out other ways to find a dentist who will see you. Most of the medical teaching hospitals would be able to refer you to either a teaching dental school,
Or I find too that the dentists who focus their practice on geriatrics or are in an area with a lot of retired people, they will often be very comfortable with patients that are complicated, because as we age, our treatment gets a little more complicated from a dental perspective. So that's another potentially, if they treat a geriatric population or in an area where there's lots of retirement places, that's Florida. Pretty much all of our dentists down here end up treating a lot of that population. But anyway, those are also maybe another question to ask. If they haven't treated people with active cancer, then sometimes that population, that age population, could be helpful also. You can advance it to the next slide, Laura.
Okay, and then between the dentist and the hygienist, the following should occur. The dentist should do, the dentist wants to get your mouth so that it's healthy as possible before starting the bisphosphonates. And they will do that by eliminating the source of infection. The dentist's role is to perform all the necessary treatment before you start any bisphosphonates. And those would be the cavities, the crowns, the bridges, and the root canals. And this part is very important, that before starting the bisphosphonates, you want to have the periosurgery and the extractions completed. And once you start the bisphosphonate, your dentist needs to communicate with other dental professionals, such as the oral surgeon, maxillary oral facial surgeons, or an endodontist, and also an ENT may be included in that too. And they all need to consult with your oncologist. And from that point, once you've started the bisphosphonates, your oncologist should be making decisions on your dental treatment. It's very important that they're involved with the communication. The dental hygienist should deliver the following treatments. We've already talked about the medical histories and the oral exams. They will review that with you, even if it was reviewed with the dentist on that same day. And then patient education. That's extremely important to keep your teeth clean, brush after every meal, floss and use a water pick at least twice a day. And then with the instrumentation, that would actually be the professional dental cleaning, either by using hand scalers or the ultrasonic scalers, or they can use both of them. And then the hygienist would decide on when your recall should be, and that should either be 3 months, 4 months, or 6 months. In closing, on my part, be extremely honest with your medical history with the dentist. Print out your patient portal with the information that I've already talked about, and keep your mouth impeccably clean.
You can go to the next slide, Laura.
I feel like I need to go brush my teeth right now. No, but as someone, and as we're advancing to the next slide, Maureen, this is such valuable information, because as someone who was on one of these I can't even pronounce the word, bisphosphonates.
Bisphosphonate.
Thank you. I remember my doctor saying, don't schedule a dentist appointment yet, or don't do your cleaning before your Zometa. And so we were on this like 6-month back and forth almost to figure out when I was getting the infusion, when I was getting my teeth cleaned. And then, I don't know if this is coming up in our discussion either. I started going every 4 months. So more frequently, and paying out of pocket for that type of health oral hygiene. So,
yes,
again, just sharing personal experience around that.
Absolutely. No, I've done the exact same thing. I go in every 3 months so that they keep a really close eye on everything. And we may get to some of this a little bit later. I always forget where we have this in the slides, but a lot of times your dental insurance will cover once every 6 months, right? And so if you need to go more often than that, or you need more surveillance, or, whatever you feel comfortable with, understanding that then you can negotiate with your dentist. Look, I'm coming this many times. This is what my insurance covers. Let's work out a payment plan in a way that there is, they're getting paid for their services, but yet, you might get a little bit of a discount because you're coming more often. Those are good conversations to have with your dentist. And because so many people don't have dental insurance, they're used to having these conversations with people. So we are still in the kind of, before cancer treatments, but this is more specific to tools and treatments that are important. So Maureen, Nicole usually covers this slide, but are you okay to do it?
Yeah, if I have any parts that are not real clear, I might skip over it, but I think I'm pretty good with it looking down this list.
You're good.
So for brushing your teeth, if you use a soft manual brush, there's one that is an ultra soft brush. I think Sensodyne makes it, and Oral-B also has one. And then an electric toothbrush. There's various kinds. The Oral-B has one with a round brush on it. I like the round brush because I have a small mouth and the round brush fits in my mouth better. And it still covers the same surface area as a traditional brush would. The Sonics have a traditional brush head on it, and both are soft. So those are good. The one thing with the electric toothbrushes, don't put any pressure on it. The brushes that come with a sensor for pressure is very good. Is once you put pressure on it, there's usually a light or something will vibrate harder. So that's also an important feature to have on the toothbrushes. Floss or use a water flosser. Use that twice a day. It's usually only recommended once a day, but you want to keep your mouth as clean as possible to keep the bacteria down. Fluoride applications. You can use there's a toothpaste that you can use. It's Prevident 5000, and that you can get from the dentist. And then you can also get a little, it is regular fluoride, and you put it in a tray, and it's a custom fit tray. And you can put that in. Usually you put that in for 20 minutes a day, and for the upper and lower. The mouthwash, look for something that does not have alcohol in it. The alcohol dries your mouth out. And the dental hygienist could do some demonstrating as to how to floss your teeth and also brush your teeth. I don't have anything to demonstrate. I probably do somewhere, but I don't have it right here. I have a great big huge tooth. It's like this big and a big long.
I have to say, this is like super weird, and I can't believe I'm sharing this, but I feel like when my dentist flosses my own teeth, that's like the equivalent of getting a massage. They like get in there. I know, right? Like no one ever says that, but I'm like, it's like, it feels so good. And I like leave feeling so clean. I just had to share that.
Sounds like you're going for
Another reason why it's good to go to the dentist, right?
Yes.
Let's see, where am
Better than getting a massage, right?
Insurance covers it, you know.
Right, right. I thought this was a great reminder as we were putting some of these slides together to discard the toothbrush or the head of your electric toothbrush if you've had some kind of infection. And when we're in cancer treatments, we're so susceptible to all kinds of things. And, you know, remembering to go back and make sure that we're discarding those things that we're putting in our mouths can be really important, so that you don't reinfect yourself, right? And so that you can heal better, that sort of thing. And then for me, I ended up having to have braces, partially because my mouth wasn't big enough for my teeth, but also because it was affecting my jaw. And we're all stressed, right? When we're going through cancer treatments, or just life, right? Life is stressful, but stress can make you clench your jaw, right? That's why they tell you to relax your jaw for so many different things, right? But that can actually cause fractures. And so that's an excellent thing to talk to your dentist and your dental hygienist about, because there are things that you can do. There are tools like mouth guards and things that they can help you with. So just important to discuss those things with your team. So I think we can go to the next slide. Yes. And we have a coupon for you guys. Coupons are great. So Maureen already mentioned the Sonicare and Oral-B as being good brands. And, you know, Costco or BJ's, if you have one of those memberships, they'll a lot of times have them on sale. It's an investment. Those, and sometimes your dentist will have those as well. I haven't noticed, Maureen, have you noticed that the heads for Sonicare or Oral-B are better or less costly, or are they about the same?
I think they run about the same.
Okay, yeah.
Yeah.
And then Burst is a brand that sells products in bundles. You can use the Dental 420 code to save up to 40% on a Burst brush. And if you're really into whitening, 25% on whitening strips. So if you look up Burst Oral Care and use that code, you can get that. Maureen, do you want to talk about biotin and swishing?
Let's see, the biotin is great for dry mouth, which I have. And they have a couple of different products. There's one that is a spray. You can spray that in your mouth. There's a gel, and you just put a little bit. They come in little packets, and you don't need to use the whole packet when you squish it in your mouth. You only need like maybe about a half an inch, and just swish it around in your mouth, and it helps to lubricate. They also have, another product is called dentum melts. They stick to the side of your mouth, and they're great for sleeping at night because they're like little tablets, and you put it on either side, right and left cheek, on the inside of your mouth, and that will melt away through the night, but it will also increase your saliva flow if you have dry mouth when you're sleeping.
Which dry mouth is a side effect of so many of the cancer medications that we're taking. And I didn't realize how important saliva is to make sure that something doesn't like grow, right? Or,
Right,
get a hold.
bacteria.
Exactly. The bacteria gets a foothold in your mouth. So yes, that's what was that again? The brand, Maureen? I didn't catch it.
I'm not exactly sure of the
We can
brand.
find it and share it with everybody. No worries.
Okay. Yeah.
No worries. No
But
worries.
the xylomelt is what they're called.
Okay.
Like the sugar xylitol, it's xylomelt. And
Okay.
the reason for the xylitol, that helps to increase your saliva flow also. And it is a sugar, but it's not the sugar that causes cavities. Let's see. Oh, this was recommended by Nicole. She swishes olive oil in her mouth for about 2 minutes in the morning, and she said that helps to lubricate her mouth. And then the canker covers, and that's what the little advertisement is on the side. They're great for if you have sores in your mouth, to just cover with the canker cover, and it sticks on there, and it has a medication in it that helps to soothe the open wound that's in your mouth. For toothpastes, Sensodyne is good if you have sensitive teeth. And Tom's of Maine, I think that was a product that you had recommended, Abigail.
That's the one that I use.
Okay. And Parodontax, that helps with bleeding in the gums. And then the prescriptions that can be prescribed by the dentist or an MD. Chlorhexidine is used for infections in the mouth, and for periodontal treatment, dentists will recommend that. And it's also used for ONJ. And Trevident toothpaste, that is a prescription that you would get from the dentist. It's a regular type of toothpaste. And then Magic Mouthwash, the oncologists will recommend that if you have open sores or mucositis or burning in your mouth when you're going through treatment.
And it can be magic, right?
It
I mean,
can
some
be.
people are like, it clears everything up, which is great. Yes. Just for a point about the chlorhexidine mouthwash, that is something that can stain your teeth.
Mhm.
And so my doctors have recommended that instead of swishing with it like a normal mouthwash, to actually take a cotton ball and soak it in it, and then apply it to the areas that are at issue, because it does have kind of an it has like pain reducing elements to it, as well as kind of the cleaning bacteria wise. So it helps if you have something that's open, but then you don't get the staining to your teeth. It comes off, right, when you go to the dentist for your cleaning, but that can be and it lasts longer too when you just dip it in the
I'm so glad you said that, because I decided to do this on my own and nobody told me I should do it.
No?
So now
Oh,
Yes. So the doctor that prescribed it to me was just like, don't do that. You know, it'll go really fast and, you know, it'll actually stain your teeth. So I was happy that he gave that recommendation to me.
And I'm happy he gave it to you too. So now I'm totally justified for doing that.
You totally are. Absolutely, Victoria. You can advance the slides, Laura. All right. So now we move to number 2, which this will be relatively brief here, but during your cancer treatment. So you've got to do all those things that we talked about in the first part, right? Which is continued in here, right? Your regular visits to the dentist, that open dialogue between your dental and your medical oncology teams. I will say that this is one of the things that's the hardest, to try to get your dentist to talk to your medical oncologist. Not that they don't want to do that, but just that's not typical. That's not normal. And so what I find I end up doing is taking the note from my dentist and sharing it with my medical oncologist, taking the note from a medical oncologist and sharing it to the dentist. And so sometimes you as the patient will have to be that bridge between those two different teams. But if you can get them to talk to one another, all the better. Because legitimately, your medical oncology team is going to want you to be on medication XYZ, and you as the patient will often have to then run to the dentist or, you know, make sure that those things, that your body is ready, your mouth is ready before you begin something. But sometimes that is on the patient to figure out. So making sure that all of your teams are completely updated by sharing notes is something that can be really, really helpful. But another thing, just from a practical perspective, is understanding what's covered on your dental plan versus your medical plan. And I will give you an example. Those 360 x-rays, panoramic x-rays that Maureen talked about, that's when you like sit in the machine and it goes all the way around your head. I always feel a little claustrophobic in that thing. Like it's going to bonk me in the head at some point. Typically on your dental insurance, it will only cover one of those every 2 or 3 years, or if you have amazing insurance, maybe once a year. However, those x-rays, those panoramic x-rays are also often covered on your medical insurance. And at least for me, I can get that at any point as long as a doctor orders it for me, whereas there are restrictions on my dental coverage.
Mm-hmm.
And so most dentists don't take medical insurance. Why would they? They don't need to. And so that can be a good example of when it's a great idea for your dentist to reach out to your medical oncologist and say, this person needs this panoramic x-ray. Will you order it? Because I don't take the insurance. It's covered on their insurance. That can be helpful. Now, the only caveat to that is a lot of times what you might see in a hospital setting in terms of the machine, it has different software in it than the machines that might be located in the dental offices. I don't have a solution for that other than to say that having the radiologist who reads the panoramic x-ray on the medical side, sometimes they will be a little bit better at interfacing with the dentist who would be reading the x-ray on the dental side. That can be complicated. But understanding what's covered can help you navigate that, right? Your dentist wants you to do that, but you know you're going to have to do it a little bit differently. That's where it comes back to this cost management, right? Like, you know, you need to go in more often. You can negotiate I'm coming in 4 times a year. My dental insurance pays for 2. Can I get a discount on the other 2? And then the last piece too is, we'll talk about this more in subsequent slides too. And Maureen mentioned this before. There are other kinds of experts other than your dentist. You have a periodontist, which is a gum doctor. You have your endodontist, who typically does things like root canals and things like that. Asking your dentist, asking your medical oncologist, or even there are dental oncologists, if there are other people that you should see. Should you go see a periodontist to have them do a deeper inspection of your gums before you start treatment? Do you need to have some dental work, so you need to get an endodontist to come on your team? Asking your dentist, asking your medical oncologist, who in these specialties, who do you work with? Because if they have a previous relationship, they're much more likely to get on the phone and talk with them. So maximizing the conversations and the team talking together can be really important. We can go to the next slide. Okay. So now we're going to talk about osteonecrosis.
The fun part begins.
So the definition of bisphosphonate-induced osteonecrosis of the jaw is a condition that's characterized by exposure of bone in the mandible. So the mandible is your lower jaw, or the maxilla, your upper jaw, persisting for more than 8 weeks. So I think that's really important. A lot of people get worried they have osteonecrosis, but it has to be something that exists for 8 weeks before it can legitimately have this diagnosis. And it's in a patient who has taken or is currently taking a bisphosphonate and who has no history of radiation therapy to the jaw. So this is where it comes, that medical history becomes very, very important, because sometimes this diagnosis doesn't apply to you because there are other things going on. The other thing I wanted to address is that a lot of people think about a bisphosphonate as a bone strengthener. A bisphosphonate is not a bone strengthener. What a bisphosphonate does is it interferes with the cell cycle. So the cell cycle, right, you're like a new person every 7 months. All your cells have died and new cells have been born. But when you're taking a bisphosphonate, it prevents the cells in your bones from dying. It interrupts that cell cycle. What's the benefit of that? Well, the cancer cells can't grow, and the cancer cells can't, when it's preventing them from going through that cell cycle, it stops them, or it helps to stop them in their tracks. However, there are 3 places in your body that are super sensitive to the cell cycle being interrupted. Your jaw bones are one of those bones, but your femurs are also affected by this interference in the cell cycle, as well as the small bones in your feet. And I'm not saying that to scare anybody, just to know that a bisphosphonate does affect more than one location in your body. Just osteonecrosis of the jaw tends to be something that people are aware of. So understanding the role of a bisphosphonate, super important. Understanding that this side effect, osteonecrosis of the jaw, is a rare side effect, but knowing what to look for is important. Okay, so next slide. So I know in the podcast it's not going to come through super clearly, but I've included a couple of pictures of actual osteonecrosis of the jaw. I was looking for the picture that I have of my mouth and I couldn't find it. I'm sure I'll find it at some point. But basically, when it presents itself, it is typically an area in your jaw that isn't covered by gum anymore, right? So it's white stuff in your mouth where it's not supposed to be white. Your teeth are white, your gums not supposed to have white stuff there.
Like white stuff because it's bone?
That is because the bone has been exposed. So when the bone has died, right? Osteonecrosis is death, right? The death of that bone. There's no more blood flow. And so the gum that's over the jaw can't live, right? Because there's no blood flow. And so that part of your gum dies and the bone underneath it is exposed. Now, that area that is dead may eventually just work its way out, right? And so that's when people will, the dentist or the doctor may actually remove the area that's dead, right? Once the body expels it, right? So the gum actually grows underneath it to expel the dead part of the bone in some of the phases of osteonecrosis of the jaw. You can also have an area that's infected. So one of the pictures here, and again, these are the least scary pictures I could find. Sometimes you have an area that's infected, that's red, that might be bleeding, that might be very, 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 very sensitive. And I will tell you, if you have these areas in your mouth, those canker sore covers that we talked about in one of those earlier slides, those are amazing. Those are lifesavers, for me anyway, because this can cause a whole lot of pain and discomfort. Victoria, did you want to jump in here with how you got diagnosed, or?
Of course, and how much time do I have? Because I can go on for a very, very long time.
I am sure you can. Maybe just give us the Cliff's Notes.
I'll just give you a very, very quick version of it. So I've been living with metastatic breast cancer for 10 years, and I've had bisphosphonates for about 6 to 7 years. And of course, I had no idea that this might be an issue. somebody kind of once told me that maybe possibly it would cause, but it's so rare, don't even think about it. So of course, the easiest thing for us is not to think about it. And I didn't. And I've had issues with my gums and with my teeth for years. So I probably should have been a lot more careful about my dental care, but I wasn't. I did do my flossing regularly and I did brush my teeth, but not, I'll be honest, not as vigilant as I should have been, especially after my earlier diagnosis. So when we moved to, after a few years, I kind of started worrying a little bit about it, and I stopped bisphosphonates. And when I moved to New York City, I actually looked for a dentist. And, in New York City, you would think you should find a dentist that would be knowledgeable about osteonecrosis of the jaw. So I went to this fairly expensive practice that they were affiliated with NYU. And I told my dentist that, look, I have a history of many years of bisphosphonates. He said, oh, I know all about it. Don't worry. It's going to be okay. Don't worry. All right, so I didn't worry. This is my modus operandi. I don't worry until I have to. In this case, this was a mistake because COVID started and I didn't go to a dentist for a year for many reasons, mostly because they were closed and I didn't look for another dentist. And so I didn't go. And that was my first disastrous mistake. So when I did go back, as soon as they opened up, I went back and I said, look, I have something on the right side of my bottom jaw that doesn't really bother me, but there's something not quite right about it. So he looked at it and he said, oh my God, you have a horrible, horrible infection. This tooth has to come out. And I think there were two teeth. He said, 2 teeth have to come out right away. And don't worry about it. I know what I'm doing. This is not a problem. And then right after we take them out, I will do we'll do the implants. And I'm happy, come out, implants, all the right words. He uses all the right words. So they came out, those 2 teeth came out. I come back and he is about to start doing the implants, right? The graft or whatever it is they do for the implants. So he looks into my mouth and his eyes go a little round. And at that point, I know what's coming. I just knew what's coming. He says to me, do you have, and I knew he was going to say history of bisphosphonates.
No.
Sure enough, he either completely forgot that I told him, or his memory disappeared over the year of COVID. I have no idea, but he completely forgot that I had a history of bisphosphonates. So sure enough, I developed osteonecrosis after my extraction. And you would think, okay, at this point, an expensive New York dentist would tell you, okay, this is beyond my competence level. Go find the specialist. No, the arrogance is incredible. He continues to tell me, oh, I know what to do. So he did something in my mouth. I think he kind of something. He gave me something. He said, put it on for 2 weeks, come back. I came back after 2 weeks. Everything looked good. He said, we're not gonna, it's fine. It's great. We're not gonna do implants. We're gonna do a bridge. Fine, we'll do a bridge. We did a bridge. A year later, and I continued coming every 3 months after this. I was very diligent about it. Then one day I was brushing my teeth and blood started pouring out of the place where they put the bridge. Long story short, I had infection in my bone, osteonecrosis of the jaw, infection in my bone, serious stuff. They couldn't, the first oral surgeon, when he looked at a general oral surgeon, he said, this is beyond me. You have to go see Dr. Fleischer at NYU. So 2 years later, when I should have seen this guy right away, 2 years later, I got to see Dr. Fleischer, who was amazing. He did the surgery. I lost 2 more teeth. So, so the end result of this story, I had a fairly big surgery. I think, Abigail, you had a similar surgery. They do, what is it called, debridement. They clean it out. They do some graft. So it was a serious surgery. And of course, I can't have implants. And so now it's a big production number. And I wish I had been smarter about it. So I wish I had seen this webinar or listened to this webinar 5 years ago. So I'm so glad you guys are doing it. Absolutely. This is so important. And I'm going to do a podcast on this after that.
Thank you, Victoria. And one of the reasons why I wanted Victoria to share that story is not for her to feel bad about the fact that she.
Well, I should feel bad, and considering that I'm supposed to be this great patient advocate who knows everything about everything, it's embarrassing how little I knew or paid attention to something that important.
Well, isn't it so fascinating that we advocate for advocacy, and then when it comes to our own health, how hard that is for us to do?
Isn't that the same with the doctors?
Yes.
It's true.
Yes. And so Victoria identified a couple of different points where going to somebody who was a specialist could have perhaps helped. Mm-hmm. But at the same time, the vast majority of people I talk to haven't gone to those specialists.
And there are not that many of them.
There aren't that many.
There are so very few in New York City. Yes. I live in New York City. I can tell you now, there are probably 3 people who specialize in this in New York City. So I have somebody.
Which is concerning.
It's very concerning. I had somebody from my support group come to New York City to see Dr. Fleischer from Boston, where Dana-Farber, you would think, would have somebody. No.
And typically the larger cancer centers will have somebody who is, this is kind of their area, but not always the case. So very, very important point, Victoria. Laura, are you able to advance the slides? There we go. All right. So there are 3 stages of osteonecrosis, right?
So I have to tell you guys, I was stage 3.
Yes, you were stage 3.
Yeah.
Which you hope generally that you can catch it at stage 1. And with treatment, the debridement that Victoria was talking about, I have multiple areas in my job where there was osteonecrosis. And one of them, because of the debridement, never got beyond stage 1. Great. That's what we want to see when this happens. However, stage 2 is when not only do you have that exposed bone, right? That white stuff where there's not supposed to be white stuff. You have pain, and then there's that soft tissue inflammation, potentially infection that Victoria was talking about. Stage 3 is when you are already at stage 1, and then you get the infections that go all the way deep into the bone. You have pathological fractures, or on an X-ray, they can see that the necrosis extends fully, meaning like down into the actual jawbone, not maybe on the teeth level. So we can go to the next slide, because there's some pictures of what it looks like when, so there's bone, right? So you have your tooth, and there's bone that goes around the tooth. And when that begins to recede, that's called the lamina dura. That is something that radiologists can see on an X-ray. Now, I will tell you, I've had multiple of those 360 X-rays, the panoramics. And if a radiologist doesn't know what they're looking at, they might identify osteonecrosis as infection, because so much like our PET scans, where cancer, infection, inflammation looks the same on or similar on these results, if the radiologist isn't looking at the history or isn't looking at previous scans, they might think that it's infection. And so if you get an X-ray, whether it's in your dentist's office or otherwise, and you see infection, that's a good indication to at least ask the question, could this be osteonecrosis? Let's look at some of the other symptoms. And so when you're looking at the perspective of the radiologist, which is the second part of that slide there, that sclerosis or loss of that lamina dura, that hard layer of bone that lines that socket of your tooth, or where they see the dead areas of the bone, again, sometimes mistaken for infection. But you as a patient might feel pain, there might be inflammation, you might see that exposed bone, or you might have a tooth that becomes mobile or loose. And that typically is something that people notice, right? As you're eating. We can go, and those pictures that I have there were from Dr. Robert Marks. I referred to him earlier. He wrote the book, Oral and Intravenous Bisphosphonate-Induced Osteonecrosis of the Jaw, History, Etiology, Prevention, and Treatment. It is not an easy read. There are a lot of scary pictures in that book, but it is the book or the kind of the basis of how osteonecrosis is understood. So you can go to the next slide. All right, so we talked a little bit earlier about different dental specialists, right? So your first line of defense when it comes to anything dental is always going to be your dentist and your hygienist. And if they know what to look for and you're seeing them regularly, they may catch something before it becomes really significant. For me, I thought I had my first cavity. I still haven't had any cavities. I thought I had my first cavity. And I went to the dentist and he's like, oh, I've been a dentist for 40 plus years and I've never seen this in real life. Can I bring everybody else in the office to come see what osteonecrosis looks like? That is not abnormal. Many, many dentists have never seen osteonecrosis outside of a textbook. And so this is where having a dentist who's aware of your medical history, super, super important. We talked a little bit about endodontists. They typically will do things like root canals, things that are a little more complicated than what a dentist will do. They're not quite an oral surgeon, but kind of that in between. Now, generally, when you have bisphosphonate medication on board, you do not want to do anything that is going to cause any kind of trauma to your jaw. A root canal is literally drilling into your jaw. That is the definition of trauma. You don't want to have that done. And so that's where if you need surgery or you need dental work, communicating with your team about when you go off of the bisphosphonate, maybe holding a couple of doses before you have that treatment, super, super important. Maxillofacial specialists, they can be surgeons. They are typically people who do things like reconstruction or when something needs to happen where your jaw is needing some kind of repair. So
these are actually medical doctors.
They are, yes.
These are not dentists, they're medical doctors.
Correct. Thank you for pointing that out, Victoria. Yes, absolutely. Ear, nose, and throat doctors sometimes will have a specialty or some experience in this area, but your dental oncologist and dental surgeons are the ones who are probably going to do some of this more complicated work. And there are very few of those, as we talked a little bit about earlier. The picture here is just another reiteration of those different stages, but then also what they typically do. So when you're at stage 1, you're probably just going to continue oral therapy, maybe surgical treatment, debridement that Victoria talked about to clear out areas of necrotic bone, and then that topical antibiotic mouthwash, that chlorhexidine that we talked about earlier. Once you go to stage 2 and stage 3, then they have to get a little more creative. They have to get a little more invasive typically. Victoria talked about the fact that she couldn't get implants. That is something that is pretty significant when you start losing teeth. If the bone is dead or the bone is not able to hold on to the implant, they won't be able to do that. They have to get a little bit more creative. But every step of the way, making sure that your medical oncology team is fully informed and fully understands what's going on, super important. I also wanted to add the caveat of a lot of times when you have osteonecrosis of the jaw, your doctor wants to take you off of bisphosphonates. And that makes sense, right? The medication that caused the issue, you stop taking that. However, as I've worked with, because I've had osteonecrosis since 2020, so going on almost 4 years now, and yes, I've still gotten Zometa. And that is because we always have to balance, for those of us with lots of bone mets, the benefits of a bisphosphonate with the side effects. And so there is one study, I cited it in one of the first slides about osteonecrosis, that talks about the definition of osteonecrosis. That one study says it's okay to go to quarterly bisphosphonate treatment instead of monthly after you've done it for a year. That is one study. Some doctors don't agree with that. Some doctors do different things, but it is important to make sure that you're talking to your doctor about the frequency of a bisphosphonate, whether or not you have osteonecrosis of the jaw, because maybe you don't need to do it monthly. I did Zometa monthly for a lot of years. Maybe it could have been better to stop it earlier. Maybe. I don't look back and get upset with my doctor, but at the same time, for all of you who are on bisphosphonates and are thinking about or concerned about the possibility of osteonecrosis, good to have that conversation. Do I still need to do this as often as I'm doing it?
But
We
you
can go to
know,
the
in
next slide.
my case, I should point out this is an important piece of information that I haven't actually looked into, but I had stopped 2 or 3 years before I got this. So it stays in your body. Be aware that it
Yes.
actually stays. It's not, I don't know, Xgiva, I think, is a little better in that sense, but Zometa and bisphosphonates stay in your body for a lot longer.
They do. They have a very long half-life. And so that is one of the reasons why going to quarterly after you've been getting it for a while, it's still protective because it's
Exactly.
in your body already.
Exactly.
Yeah. We can go to the next slide, Laura. Okay. So wrapping up, right? What are the reminders, or what are the things that we think that you should take away from this? Continued good dental health during cancer treatment is a must. And I understand we've talked to quite a few people as we've been making some of these presentations in different groups who are afraid to go to their dentist. And a lot of that is because it hurts. And especially when we're going through treatments and we have dry mouth or our gums are affected, it's painful. I totally understand that. It's incredibly painful for me when I go to my dental office to get cleanings. And what I have them do is put that numbing cream on my gums prophylactically at the beginning. And then I'm not flinching. And then I'm not tensing up. And then I'm not afraid of what they might do. It absolutely helps. And so asking your hygienist, how can we make this more comfortable? Some hygienists will do the cleanings by hand. Some of them want to use, different implements that have, they shoot water, or they, do other things. Talking through with your hygienist, what tools are you going to use? I have a lot of pain with X, whatever, that area, or upper or lower, whatever it is. Talk to your hygienist about those things, because numbing cream is one of the things that I've used, but also that allows them to use whatever tool they want. Otherwise, I had to tell them they had to do it by hand. And that could take a long time because, yes, I haven't had cavities, but I get a lot of tartar. So cleanings can be a little bit involved for me. So ensuring that you have dental providers who know the signs of osteonecrosis, super, super important. We're not medical professionals, and it's really hard to see inside your mouth unless you have the tools that the dentists have, right? And so having providers that know what they're looking for and know what it is when they see it, or think back to that textbook when they were in dental school and say, oh, I know what this is. Super important, right? That's why it's so important to make sure that you have told all of your medical providers all of the things that you're doing. Assembling those experts for your team when you have symptoms, super important, right? So don't ignore, don't avoid, making sure that you have the right people looking at whatever's going on in your mouth. But managing symptoms, managing pain, super important for quality of life. It's really hard to eat if your mouth hurts, right? So making sure that you're having the right, the right pain management things, or, having them address whatever is going on, like infection, antibiotics, those kinds of things, to make sure that your pain is kept under control is super important. I don't know if they did this for you, Victoria, when they did the surgery, but for me, when they did the debridement surgery, they also did something. I like to say they fried the nerves but they made sure that as the osteonecrosis is advancing, because it can,
Yeah.
I'm not having the same amount of pain because they dealt with the nerves when they went in there and did that surgery. Did they do that for you, Victoria?
I don't think so.
Okay.
Hmm.
So I lost tooth number 19. Tooth number 18 is going to.
See, I think the difference is he went a little broader. So he
Yes.
took out 2 extra teeth, and maybe
Yes.
that's why. Yeah.
Maybe that's why. Yeah.
Yeah.
But I can tell you that when tooth number 19, the tooth that I lost, when that was loose, it hurt like the dickens because as it moved around, it was touching nerves, right? And it was really not fun. I have the same mobile, it's similarly mobile, tooth number 18, the next one, but it doesn't hurt the same way because of what they did to the nerves when they went in there. Like they were anticipating that was something that was
But
going
did they?
to.
But does that mean that they made that tooth even weaker than it was before?
I don't know. It's possible, but this whole area in my mouth is numb.
Yeah.
So I can't feel
Really?
as that tooth is moving around. So maybe it hastened the fact that as the bone has receded, that sort of thing, perhaps. Yeah. But as I've said in each of these presentations, I would far rather lose a tooth than break a bone. And for somebody like me, I had a huge number of bone metastases at diagnosis. My femurs were at the point of I needed rods. So I have rods in both femurs because they were super worried that my femurs were going to break because of all the cancer. It's really, really, really debilitating when you have fractures or when you have a bone that breaks. And so, trying to put some of that in context, right? I'm happy to lose a tooth or two if I don't have a broken bone, because those are a whole lot more painful and it takes a whole lot more time to recover.
And just be aware that if you lose your teeth to osteonecrosis, as I said, no implants. So you wind up having to have a partial, whatever those things are called, and that is not fun at all.
Mm-hmm.
Yes, a little bit of prevention, a little bit of addressing some of these things so you don't end up in that situation, super important. So when there are symptoms, when there are issues, seeking out medical care, making sure that you're with somebody who knows what they're talking about. And I think that question that we talked about at the beginning, which, asking your team, your existing team, how much have you seen of this? Maybe if Victoria had asked that person who thought that he was an expert, well, how much have you actually seen?
That is the question I did not ask, and I should have.
Maybe, right? But hindsight's 20/20, right?
Of course, it always is. Yes.
Of course. And so this talk and what we're talking about is definitely not to point fingers at anybody or make anybody feel bad. It's more about how can you be proactive? How can you think about what might happen? And seeking out peer support, talking with people who have experienced this. There are a couple of Facebook groups that have gathered people who have experienced osteonecrosis of the jaw, not just from cancer treatment, but because you can encounter that in other scenarios as well. But talking with each other can be really, really helpful. Sometimes it's a little scary because people, if they have things that have happened that aren't great, that can be a little bit daunting. But reaching out for support, talking about this stuff, like our commitment on this MBC series, peer support for those things that our medical teams are not talking about, aren't maybe aware of, that's something that we can do to help one another so that we can get to the right experts. So I don't see that we've got any live questions now. But certainly if anybody is interested in learning more, feel free, you can contact me. My email address is abigail@survivingbreastcancer.org. Certainly if you email Laura at survivingbreastcancer.org, she would make sure that the question gets to the right place. But our only goal in talking about these things is so that you as the patient are empowered to ask the right questions, that you as a patient are empowered to seek out the right experts, and that you as a patient are not sitting there worrying what could potentially happen, what might happen, but you're equipped with what do you do when something happens. So that's our goal for today. And certainly if you have any specific dental questions from what Maureen presented, I'm happy to pass along those questions to her. I'm not going to make her give her email address out, but she's a great resource and has been super helpful in just kind of looking at those very important aspects of dental health, which is so important.
And I just wanted to say one last thing. I'm sorry, Abigail, I interrupted you.
No, Victoria.
So this is becoming an issue for early stage people as well. This is not just for the metastatic patients. That's right. Adjuvant bisphosphonates are becoming the thing.
Yes. Thank you for throwing that in, Victoria. So yes, this series is definitely focused on the MBC community, but so much of what we've talked about today is applicable to every person. Because as our mouth health is, a lot of times that really flows to the rest of our body.
Yeah.
And that's so important for everybody to consider. So thank you, Victoria, for saying that. All right, so please join us for other discussions. We're doing this twice a month on a Wednesday at 7 o'clock Eastern. Sorry, I couldn't even figure out what time it is. And we have a lovely lineup for the rest of this month. But I did just want to highlight the fact that we are reprising our most often attended webinar on Pinktober. So we're gathering a group of NBC folks to talk about what is the experience of Pinktober, how they're dealing with it, how it might have changed. And that is a little bit outside our normal schedule. And that is on Sunday, the 29th of October at 3 p.m. And Victoria and I are going to be in person together when that comes around. So super exciting. But I don't want us to end this before I acknowledge that for those of us living with metastatic breast cancer, October can be a difficult month. And everybody deals with that in different ways. And so acknowledging that some of the things that are typical for an October, some of the walks and the celebrations and the feather boas and jewel encrusted bras and all of that, that doesn't resonate so much with those of us in the MBC community. And if that is something that hasn't quite sunk in yet for you, or you're not sure how to deal with that, this panel discussion on the 29th is always a really amazing discussion. And this year we're going to have a man on the panel who is living with MBC. So I'm super excited to have Kirby come and speak with us about his particular experience, since men feel even more left out of all of the pink soaked stuff that happens during October. So very much, committed to our goals at survivingbreastcancer.org, which is all about education, empowerment, and connection with other people who are living with the same thing. That's what we're doing. So I hope you will join us for that discussion. It's my favorite discussion.
Yes, it is good.
Yes. So Laura, did you want to talk about anything else that's happening at SBC? I know there's always a lot of wonderful things happening.
I didn't realize I was just muted. I'm like so excited. That's such a great episode. So I'm really looking forward to it. No, amazing. So educational. I am so glad, Maureen, to meet you for the first time. I hope this is the first of many. Victoria, always such a pleasure to have you. And Abigail, thank you for moderating. This is what we do.
All right.
And to all of you, we will see you in 2 weeks.
Can I quickly do a plug for me?
Of course.
Very quickly.
Absolutely,
I usually don't do
Victoria.
it, but this is important. This is important. So the podcast that I produce with a group of people, and I've had Abigail on every time I need help. Abigail is my go-to person. The podcast that we produce is called Our MBC Life. And every year in October, we do an episode that we call We Remember. It's the memorial episode for those of us of our community who passed away within the last 12 months. So the next episode for that is on October 18th, and I hope everybody gets a chance to listen.
Thank you. So important.
Yeah.
It is very important. It seems like this year we've lost more people but it seems like every year we lose more and more.
Well, our hearts keep opening up we are inviting more people to
That's true.
hug and to love
I think
and
you're
to
right.
know.
I think
Yeah.
that's exactly it.
Yeah,
So
we've
thank
lost
you.
a lot for sure.
Thank you for sharing that, Victoria. I mean, as heart-wrenching as it is every year, you guys do such a great job of highlighting.
With your help every year.
I'm always happy to help, but highlighting the legacies of
Yes.
those people that we've lost, and really helping everybody to process their grief. I think that's also part of the reason that October can be really hard, is that
Exactly.
in our world, it's not about celebrating being cured. It's unfortunately about grieving those who have
And
lost
of course,
their lives.
the irony is
Yeah.
not lost on us that
Yeah.
it's the October 13th that we get as a
Yeah.
day to remember metastatic breast cancer. And this year it was
It's on a
Friday.
Friday the 13th.
There'll be a lot of good memes for that. I just
I'm sure.
oh, well, so
Yes,
beautiful.
but a plug for the Light Up NBC project, right? So on
Yeah.
October 13th, there are landmarks all over the United States
That's
and
right.
other countries, and it's growing every year. Light up in the NBC colors. And if you're interested in meeting up with other people who are living with NBC, it's a great time to get together and go to one of those landmarks. I'm hosting a gathering here in Orlando at one of our landmarks that are lighting up, and we can redeem the Friday the 13th time of just being together and
That's a great
sharing
idea.
stories with each
Yes.
other. Yes. And hey, they raised $500,000 last year for NBC Research during their live program. So it's a great program. So just because at SBC, we're not about being the only organization. We are about partnering with other organizations that are doing good work. And
We can't do it all. We can't do it all.
But
Exactly.
you're doing a really good job of almost getting there.
Thank you, Victoria. I'll find sleep one of these days. But thank you, everyone, for tuning in. As always, as we're at the top of the hour, this has been such a pleasure, so educational. I am about to schedule my dentist appointment and definitely floss tonight. So thank you all. I really appreciate it.